Um, so I'm going to talk about models of telebehavioral health and integrated primary care, or using telebehavioral health to do integration. This is a fairly, it can be a challenging topic to address, in part because it's still very early in the development of this type of program. There are, of course, integrated primary care programs, and they're not ubiquitous, but there are certainly plenty of them out there. And there are telehealth and telebehavioral health programs, but mixing the two is a little less common. So what I want to do today is talk about, my slides to move here, talk a little bit about integration models, just so that we're all on the same page. I think probably if you're joining this webinar, you probably have some idea of what we're talking about and what the need is, so I won't spend a lot of time there. Then I'll review some of the business models that you can use in a telehealth setting, because telehealth, at least at this point, is not quite exactly equivalent to in-person care in terms of billing and reimbursement, at least the sort of arrangements under which you can bill for it, and it varies a little bit by payer. So I'm going to go into some detail in talking about how Medicare reimburses and pays for telemedicine, just as a way of providing some background, and then say a little bit about other types of payers. And then we'll talk about integrating those two things, our desire to provide integrated primary care and our ability to pay for it when it's provided via telehealth technologies. And I'll give you spend just a little bit of time on some technical issues, technical concerns, just because it's important to just have a sense of what's available technically, and then how that may limit or enable some of the things that you can do. As I'll make a point later, technical issues are certainly not the first consideration, and they're not. Most programs don't stand or fall on technical issues. They stand or fall on other administrative types of issues. But we do need to see what's possible. So I'll go ahead and say a little about that. So to start off with, just to mention something that most of us in mental health and primary care are aware of. There have been some significant shifts over the last 20, even 30 years now, in the way mental health services are provided and delivered. There are, for many years, mental health and primary care demand has been growing. And many of you are going to be familiar already with the idea that up to 70% of primary care encounters have some sort of a psychosocial component. 70% of the psychotropic medications that are prescribed in the primary care setting. In fact, recently, well, 2005 is not really recent anymore, but Wang's study found that there were more mental health interventions being provided in primary care than in specialty care, which is pretty remarkable when you think about it, but it also underscores not only the demand for mental health in primary care, but also the types of interventions we're talking about. You know, whether it's a little bit of counseling that would be provided by a primary care physician, or an antidepressant, which are now, since the advent of the SSRIs, are much more safe to prescribe in a primary care setting. But a wide range of things are now available that the primary care physician or nurse practitioner or other primary care practitioner can provide that count as mental health interventions. And it continues to be the case that the majority of encounters in primary care either have an express primary mental health component, or certainly scratch a little and you could find it underneath whatever the presenting concern is. So it's mental health issues in primary care are ubiquitous, common, and are fairly commonly treated, though still undertreated. And then an important thing to recognize as well that comes from the Cherokee Health System and others who've been pioneers in this is that every primary care encounter or presentation has some sort of a behavioral health component, whether it's as simple as the way that the patient is requesting services or what types of services they're requesting, all the way to complicated, long-standing behavioral health issues that are driving chronic disease of some kind. So there's a whole spectrum of ways in which behavioral components impact the primary care setting and the kinds of services that are delivered in primary care. You wouldn't be listening to this webinar if you didn't have some idea already what sorts of gains you hope to get from using telebehavioral health, whether that's reducing costs in some way, to reducing time and travel expense, or another cost savings that isn't always recognized right up front is that you can much more efficiently allocate and use partial FTEs, whether that's hiring or contracting for services for a few hours a week, or taking providers that are needed or are underutilized in some other setting and deploying them into a different setting using telehealth, so you can make use of those partial FTEs much more efficiently. There are programs certainly that are using telehealth to improve quality and improve access, and there's lots of research out there showing that it can be done. It is not automatically accomplished just by implementing telehealth, and I think that's probably clear to anybody who thinks about it, but certainly it's a tool that can be used to improve quality, as well as other types of integrative activities that we are trying to do in primary care and in any kind of a healthcare environment. Improving collaboration among clinicians, or involving a patient's family in services, or any number of other ways where we're trying to improve care through better communication processes. And also, as many mental health providers are aware, or primary care, telemedicine, telehealth use of those technologies can allow one to get providers or recruit providers from outside one's local catchment area. So you can use providers from all across the country, as we have been doing at Oaklawn, where I was the Vice President of Integrated Care and Information Technology. We've been using providers from the Chicago area and even as far away as California or Indianapolis to provide services, and these are providers that we couldn't get on site because of our kind of semi-rural status here in northern Indiana. The types of services you can pursue and get delivered using telehealth in a primary care setting could range all the way from just emergency mental health services. Often inpatient admission is what's being sought. You can get psychiatric diagnostic services, of course, medication management, whether provided by psychiatrists or advanced practice nurses, psychological assessments of various kinds, psychotherapy from a wide range of providers. All of these services can be provided over live video. And I'm limiting what my comments to live video and billable services. There's certainly a whole part of the domain of telehealth that involves asynchronous services, store and forward services, patient monitoring services. There are lots of telecommunications types of systems that can be used to enhance healthcare, but we are focusing on live interactive video for purposes of this presentation. And of course, when we're thinking about the different sorts of providers that we want to deploy in our primary care setting, we're thinking about the kinds of things that they can provide. And counselors, licensed clinical social workers, or what Medicare or federally are defined as clinical social workers. Various states will have other types of licensure that fit within that sort of a setting, but those providers are limited to the kinds of diagnoses that they can provide and the kinds of interventions, psychotherapeutic interventions that they can provide. Certainly they can provide brief focused therapy in primary care. It is that type of training is growing in programs, but many existing clinical social workers haven't been trained in those types of interventions, just as many clinical psychologists have not been trained in those types of interventions or that type of a setting. So it underscores the need to acclimate your providers and help them get up to speed and get comfortable working in a primary care setting if they're going to do that sort of thing. Often, though, what is really desired in working in integrated settings, or at least the sort of ticket that gets organizations interested in these kinds of services, is the perceived sort of highway from primary care into psychiatric specialty services and inpatient services. And oftentimes that requires a psychiatrist to provide that liaison or admitting privileges into an inpatient setting. Now, that's much more common in hospital emergency departments, for example, where you are more likely to see psychiatric emergencies present, but it can also happen in primary care as well. The main types of programs that exist in an integrated primary care setting, however, don't focus on direct access into inpatient services primarily. They're primarily looking at ways that behavioral health services can enhance the common sorts of treatment plans and treatment goals that exist in primary care. Now, certainly from time to time, psychiatric emergencies are going to present in primary care like they do now, and it's nice to have access, rapid access, into inpatient and other specialty mental health services. But by and large, the psychiatric emergencies tend to present to emergency departments or psychiatric inpatient units rather than primary care doctors. So it's not generally the type of service that it's not the setting where those types of patients normally present. And so I want to focus on the services that support primary care physicians, and that's the idea of an integrated model. One of the most popular models, one of the oldest, is the 4-quadrant model, and I won't spend a lot of time on this. The basic idea is to break down mental health and primary care services along 2 axes, and to underscore the idea that you can provide sort of minimal behavioral health services in a primary care setting, quadrant 1 in the lower left. And even quadrant 1, that sort of minimal setting, is probably fairly advanced for many primary care settings because it involves systematic screening of patients for mental health issues and the availability of a stepped care model and some sort of behavioral health consultant. BHC is a common acronym for the type of person, a clinical social worker or clinical psychologist that might work in a primary care setting, a behavioral health consultant, or a case manager that would be responding to positive screens for mental health conditions or behavioral health condition, and then working in that setting with at least with some minimal interaction with the primary care providers. That's a model that is presumed to be sort of basic in this 4-quadrant model, but is still not common in primary care. Well, it's not uncommon, but certainly it involves a level of sophistication, at least with regard to screening and integrating behavioral health folks, that is not always assumed or can't commonly be assumed in primary care. The quadrants then in this model just basically add more intensive behavioral health services on the vertical axis and more intense medical services on the horizontal axis. So you can see quadrants 2 and 3 really add more sophisticated specialty care to that basic model, whether it's more sophisticated behavioral health services or more sophisticated specialty medical services on site. And then quadrant 4, where we presumably are all aspiring to be, involves both specialty mental health and specialty medical services integrated on site. I won't spend any more time on that model. It's a helpful model for evaluating where one exists and exploring what types of services are available. But in practice, the kinds of models that you see more commonly are these two that I want to talk about now. And in some ways, the four-quadrant model is useful theoretically, but practically it can be less useful because it comes down to what exactly are the services you're implementing and how exactly are they being implemented. One of the things that, just as an aside here, one of the things that the telehealth resource centers have found after working with dozens, maybe hundreds of telehealth programs across the country is that there really is not there are not just a few models. There isn't one model for certain, and there's not just a few ways of doing telehealth. And every organization is going to have to figure out how to integrate telehealth as simply telecommunications services into the types of healthcare services that it's providing. And so there are a wide range of ways that organizations choose to do that based on their local resources and the kinds of things that they want to achieve. So there is not one way to do it, and if you follow these 5 steps, you're guaranteed to succeed. But there certainly are nice models out there that one can get inspiration from, take bits and pieces from, and build a system that works for your own organization. Probably the most widely known and widely emulated program in the country is operated by the Cherokee Health System in Tennessee. They have fully co-located, and co-located is not the term they would use, fully integrated primary care and mental health services in their primary care clinics. It's team-based treatment. Behavioral health consultants are part of the primary care treatment team. And so, already there you're talking about team-based primary care, which is also not ubiquitous in primary care. This is a new idea. This is still relatively new. You can't assume that you've already got team-based care operating in primary care. So the telehealth as a sort of advanced service provision model is coming to popularity and being implemented alongside other advanced models of care delivery, and all of these have challenges related to their implementation. So all that to say is, trying to add one new model is hard enough. Trying to add two at the same time multiplies the effort involved, and so it's not, again, it's not a simple pathway. But Cherokee's been doing this for years, decades even, and has been honing the way that they provide services in an integrated on-site model. I don't know if they're using telehealth in their integrated care system yet. It's a question I ought to pursue, actually, now that I think about it. But certainly their on-site model is one that's widely emulated and very popular. And I'll say a little bit more about it in a minute. A step down from that, and where a lot of programs are across the country, are what you might call partnership models, where you have a primary care clinic or setting or system of some kind, and then there are various agreements to provide supplemental services, whether those services are provided on site or off-site by referral. And this is basically a sophisticated way of saying everything else, right? Because we all have agreements with other providers to see my specialty cardiac patients, or my specialty neuro patients, or my specialty behavioral health patients, whatever they are. Whatever those specialty needs are, I refer out to other folks in my community if they're available. And so a wide range of arrangements can exist there to provide those supplemental services. Now, as a way of drilling down into integrated mental health care, integrated primary care, I want to refer you to the link at the bottom. Cherokee Health Systems has put out a slide share. These slides are available publicly, and I really encourage you, if you don't know who they are, or you haven't been exposed to the models, take a look at these slides following the link at the bottom there, and these slides will be available to you. And find this whole slide set. But here's one slide lifted out of that set that talks about the difference between fully integrated care, which they provide at Cherokee, versus what's called co-located mental health. And the main differences are that you have, in a co-located model, you have access to ancillary services, but they are separate services. They're conceptualized as mental health services. And so you can refer a patient into those services. It may be easy to make that referral. The patient is able to come to the same location and see their mental health provider, but primarily the communication between that provider and the primary care provider is by means of a write-up, an evaluation, a note, an integrated medical record, whatever that is, whatever sorts of integrated or whatever sorts of written communication pass between those providers. The mental health services are usually scheduled separately and provided, in a sort of a treatment plan for a mental health condition, separate from, your treatment plan for your medical condition or problem, whatever it is of the day. And there's much more of a mental health specialty orientation. Whereas in a fully integrated model, really the behavioral health clinician is working at a behavioral health angle on the entire clinical picture. And in what ways can a behaviorist, which is what the Cherokee folks sometimes shorten what they call the mental health folks, in what ways can a behaviorist enhance the care that's being provided? And not just the mental health aspects of the care, but also other behavioral aspects of the care, whether it's follow-up for a chronic condition, whether it's, a mental health condition that is impacting a chronic condition. In lots of ways, behavioral health can impact the overall presentation in primary care, not just with anxiety and depression and adjustment issues or phase of life kinds of problems or those sorts of things, but also in setting up schedules for following through on care, for setting up ways for helping the patient fully express their responses to treatment, because a doctor can only treat what the patient will tell them the symptoms are, or can only get feedback about whether treatment is working insofar as the patient is willing to share that detailed information about side effects and main effects and all of this, and all the things that go into a course of treatment. So for fully integrated care, the behaviorist's role is much more about enhancing and supplementing a total care package in a variety of ways. And their communication on the team is much more verbal, much more real-time, and team-based. And so I put all this out there just to underscore the differences between fully integrated and co-located care, and also help you to start thinking about ways in which you can provide co-located care using telehealth systems, and what some of the limitations of those systems are when you try and go to fully integrated care. For example, one of the examples of fully integrated care that I saw in a hospital that I worked with kind of was developed sort of by accident or by necessity by a group of nurses who were working with a cardiologist who was consulting with a patient in a hospital setting, and they had just happened to develop equipment such that that their telemedicine equipment was an iPad on an IV pole. And the nurses really liked this, as opposed to the large telemedicine carts that they had at the hospital, which the nurses tended to not use. They would rather grab one of these IV poles with an iPad on it, and they would roll it around. And they would bring it into the room, and the nurse and the doctor and the patient could talk together. And then from time to time, the nurse would have something he or she would need to say to the doctor, and they would just step out of the room. They'd pull the IV pole out of the room, and they would talk together and consult, and okay, we're going to go back in and talk to the patient. They go in and talk to the patient. And in that setting, the physician coming in via the iPad on the IV pole could operate in much more of a live, present, integrated way than if the clinician was coming in via a TV mounted on the wall or in a consultation room somewhere that limited how they could interact. And so I present that to underscore the ways in which technology can enable and can also limit what you can do in an integrated setting. Another story that we have about that with response to integrated primary care and behavioral health is a system that we developed at Oaklawn Community Mental Health Center that had a partnership with primary care clinics to provide a clinician on site to take handoffs from a primary care clinician. So the primary care doctor sees a behavioral health issue that they would like addressed. They can just tell the patient, I'd really like you to see Phil, the clinician we have on site here. And so they'd walk them down the hall and say, Phil can help you with this problem. He's really great. They would knock on the door, make the introduction. If Phil was in a session, he'd jump out and meet the patient, say, hi, can I see you in 20 minutes? If not, can I see you tomorrow or next week? And they would set something up, and then he'd go back in the session. If he didn't have a patient currently, he could see the patient right away. And that was all working well in an integrated model. But then some days Phil needed to be off site. And so what we did is we ended up putting a video unit in the room, more or less where Phil would sit, and it was constantly running. So no nurse needed to turn it on, no doctor needed to turn it on. It was constantly running. And so the doctor could just walk into the room and say, hey, Phil, are you available? I've got a patient I want to introduce. Phil's on camera. He can say yes, or he can say no. He can mute himself, whatever. And if he's available, then the doctor can just bring the patient into the room, make the introduction over video. Patient can sit down and start talking if it's appropriate at that time, or can, make arrangements to come back at another time. So again, another example of how technology enabled a process that was really designed to be in person. And if the technology had been designed a different way, might not enable that sort of integrated service. So just some things to get you thinking about that, and a kind of a long digression. As I was saying before, most programs kind of fall into this middle model, somewhere between agreements and full integration, where you've got either a behavioral health consultant available on site, or fairly rapidly available, where you've got a psychiatrist available for consultation, perhaps, maybe you even have both, but one or more components just isn't available or isn't well utilized, such that you don't have a really fully integrated model. And that's common. It's not to say, that's sort of the way it is, because these programs are difficult to establish, they're difficult to maintain. There's a lot of moving parts, and it takes a while to change culture. Just as you could imagine, team-based care is a large culture shift. So is integrated care. So if we break down a program into its components and say what are the basic pieces, it really becomes something like this: some sort of a screening system in place, because unless most providers, and this will vary, you will know your providers better than I would, but most providers aren't going to provide a steady stream, are going to initially underutilize a behavioral health clinician. Now, there are some settings in which they won't, and we certainly across the Oaklawn network had primary care sites that immediately overutilized the clinicians, or the clinicians were just impacted from day one. But there were most settings where they were underutilized. Physicians don't have a referral to a behavioral health clinician as part of their regular rhythm that they get into. And certainly physicians work in a rhythm, the kind of volume that they do, it works for them to just get into a pattern and do that pattern over and over. And if seeing the behavioral health clinician is not part of that pattern, then they're apt to just jump over that and move on to the next step. So some sort of a screening to point out, underscore, okay, this is a patient, lights go off, this is a patient that probably ought to see the behavioral health clinician. You have a clinician like that on site. They are comfortable working in a primary care setting, which is not a small thing for most behavioral health folks. They are comfortable delivering care that is very brief. I say 2 to 6 sessions, because that's really, you can do longer, you can do shorter. There are a lot of interventions that are single session interventions, but you need to have in your mind a way of working with a patient over a couple of sessions, just to get them oriented, help them address the current issue, and maybe set up a plan for a couple of follow-up sessions to underscore what you've done. But it really is a very, very brief model. Aperiodic. This means that, once I see a behavioral health clinician or I see a patient in that setting, I'm not saying, okay, I want to set up 6 weekly sessions for us to do this treatment thing. We might do that, but more often it's, okay, when can you come in next? I think in a couple of weeks might be good. And then when you see that person in a couple of weeks, you ask, how are they doing? How's the plan working out? If it's working great, you feel okay, all right, we're done. Or if it's not, well, maybe you can come back in a couple of weeks and let's do another refresher. It's much more kind of on an as needed basis, as much as needed than it is, I've got a 12-session protocol I want to run you through. It's really not that. SBIRT, screening, and brief intervention and referral to treatment for substance use, is very commonly used. It's a sort of a protocol, conceptual protocol for adding substance use services, or really doing a brief intervention in primary care and then referring to specialty substance use treatment. And those tools are very necessary, very useful in primary care. And then also access to psychiatric consultation, whether that's patients seeing psychiatrists for medication management, or I'm referring to another acronym here, ECHO-style case presentation and discussion, where primary care docs can present their psychiatric patients to a psychiatrist in a group setting and get sort of group continuing education and evaluation and supervision, if you will, from a psychiatrist saying, okay, here are the kinds of things you can do in primary care with this type of a case. And then at what point do you take that case and say, all right, I need to send this off to specialty mental health care? And doing that in a live online setting. That's what the ECHO model is all about. And it's really about increasing capacity of primary care providers. In some cases, primary care providers can be provided with sort of treatment algorithms for various medications that they can use via an algorithm, just to kind of help them ramp up into providing medication management for psychiatric cases. Usually that's going to be something that they'll want to work out with a psychiatrist that they're working with, to see what sorts of, first line, second line, third line kinds of things they could try before a referral. I refer here in the slide to the Texas Medication Algorithm Project, which was an ambitious project to outline algorithms for primary care physicians to use various medications in the way, in kind of making psychiatric specialty methods available to the primary care doc in an algorithmatized way so that they could provide that kind of care. Unfortunately, the project itself was a little controversial because it tended to, in some way sponsored or funded by pharmaceuticals, and tended to promote expensive proprietary pharmaceuticals over generics that were just as effective. And so it's been controversial. So take those recommendations with that in mind, certainly, but to access a resource that can give you an idea of what it would be like to have a plan for saying, okay, with a depression patient, I can do this, this, and this, and then at this point, I can then refer them if they haven't responded. Is a way to integrate, to interface with ancillary or with specialty care. I won't spend too much time here on common barriers. I think one of the things that came up for us the most, and I'll underscore, is that sometimes there's a gap between what primary care doctors want and what specialty care doctors are willing to provide. And often in a primary care setting that is where there's a huge mental health demand, what the primary care doctor wants is to be able to offload some of those patients to somebody else to manage them. And unfortunately, that's a valid concern, but the psychiatrist wants to help. Often they're impacted as well, and they want to help the primary care doc increase capacity. So there's a bit of a mismatch there. And so that can be a challenge, as well as what I said before about physicians not quite knowing what to do with behavioral health clinician and what sorts of cases they can help with and how to best utilize them. I'm going to skip through this. I want to spend, I don't know to what extent all of you on the call are familiar with how telehealth can be billed. Actually, I'll back up a second. What I can tell you is that, what I can tell you up front, without going through a lot of detail, is that any of these facilities that you're working at with any of these types of providers, and any of these payers and any of these services, there are at least some ways that you can be paid for these services. There are at least some ways that there are payment streams, reimbursement streams available. Not everyone for every payer, not every location for every payer, but there are many combinations available. Unfortunately, it's not just, yes, whatever you're doing can be paid for. And this is really shouldn't be that surprising. I mean, healthcare itself is very complicated. You can't get paid for everything that you can do in primary care as well. But certainly that's also the case in mental health care. I have a number of slides in here that go over Medicare reimbursement as an example. But I don't want to spend too much time on it. They're in here for your reference. I want to just point out that Medicare is very straightforward in that they carve out telehealth services in the sense that they say certain providers in certain locations and certain services are paid for. And that's kind of the carve out nature of it. It's independent of anything else that you're doing, as long as the patient is in a facility in a rural setting, and they are one of these list of providers that I'll show you in a minute, and they're providing a certain code. You can be reimbursed from Medicare. Everything you need to know is in this purple document that Medicare CMS updates every year. You can get it from UMTRC. You can get it from any of the TRCs. It's a very handy little straightforward guide to using telehealth with Medicare. This is a page from that guide, and you can see that on the left side I'm listing the types of providers that Medicare will pay for, and it's a pretty good range of people that you're using now for mental health services, certainly. And then on the right, you see I've circled the mental health codes that Medicare will pay for, and you can see it's the meat and potatoes of mental health care. There's nothing in there. You can use those codes to do just about anything you need to do in an integrated setting. Furthermore, about how Medicare conceptualizes telehealth, just a couple things you need to be aware of. Number one is that Medicare assumes that the patient presenting site and the provider billing site are two separate entities. And this is just a historical anachronism from when Medicare came out with these rules. They assumed that it would be some academic medical center somewhere in a big city billing the professional fee, the CPT code, and some rural facility presenting the patient that would bill for a technical fee, originating site facility fee, and that those would be separate entities. So from Medicare's perspective, although assigning billing is not prohibited, Medicare doesn't really recognize that, doesn't know what to do with that. There's no real regulation around it as far as telehealth is concerned. And per CMS, the rural health clinic or an FQHC can't be a distant site. That is a provider site for telehealth. So if you contract with a psychiatrist and they turn over billing to the FQHC, and then the FQHC tries to bill Medicare for that professional component, Medicare is likely to say, you can't do that. You can't be the distant site, even though you're not technically. You can't bill the professional component, is what Medicare is saying there. Now, Illinois and Indiana both, in their Medicaid programs, do allow that. And I can tell you, I'll tell you straight up, it's just a muddy area between CMS and Medicare and Medicaid. There is no one can stand up and say this is exactly how it should work, because it is an area that's in flux, and it's an area that is is not clear exactly what the policy is, even though policies look clear when you start to apply them, especially in this turning over billing sort of arrangement. It isn't always clear what you can and can't do. And there are certainly plenty of clinics turning over billing, contracting with providers, turning over billing and billing as local entities. And so it is possible to do it. It's just a little bit unclear in the regulations, and you ought to be aware of that. And again, like I say, Illinois and Indiana Medicaid allow for that specifically, but Medicare as a federal program officially does not. The other thing I want to point out on this screen, bottom left corner, the patient has to be at a facility or doctor's office that is located in a non-metropolitan statistical area. And it breaks down as far as a census tract. So it's not a county. It used to be a county, but now counties are subdivided actually into census tracts. But the only official way that you can find out for sure if your originating site is rural is to go to this link that I've given you at the HRSA data warehouse and put in an address, and it will tell you yes or no. So go there, get your eligibility to bill, and then you can see about Medicare only. Again, Medicaid in all of the states that UMTRC covers doesn't care about the location, so don't worry about that for Medicaid billing, but Medicare does. So a little bit more about Medicaid. Illinois has a restriction that a licensed person has to be required to present to the patient. There's actually legislation right now to change that. Indiana Medicaid is fine with coverage similar to Medicare. Michigan, yes, Michigan Medicaid provides services even more than Medicare with some limitations. And Ohio is a little more restrictive than Medicare. Ohio Medicaid, a little more restrictive than Medicare and without the rural limitations as well. So Medicaid programs across this region are good. Check with your local TRC or your local Medicaid office for your own state if you're from a different state. And then for commercial payers, and I'm just kind of blasting past this, but in general, parity, what we mean by parity is that a commercial payer has to pay for a telehealth service the same way they would if it was provided in person. And both Indiana and Michigan have solid parity laws. Illinois has a parity law, but it just says plans may pay, so most don't. It's a parity law without any teeth. And Ohio does not yet have a parity law, though they're working on it, or there have been efforts to work on it. Again, follow up with us at UMTRC if you have questions about that. So putting the two together, what I recommend, and you've probably got some ideas already about how to do this, but that you look for a service that you can provide already a meetable need, a service that you can provide that shows demand. And again, if you can't make money at it in person, you're not going to make any money in telehealth. And if you telehealth doesn't magically create either service provision or utilization or anything like that. It allows you to more efficiently meet a need that you can already provide. So you have to have available staff, and it has to fit with your mission and all of those things. Then then identifying the stakeholders and bringing them together to look at the need and define the need. And again, UMTRC or other TRCs can help you with tools to do this, to help you work through this in a systematic way, and then find out what sorts of services make most sense in your setting. You probably have an idea about that already. But all of that is sort of by prelude to saying, don't start with equipment, because telehealth is not an equipment issue or an equipment question primarily. If you've got a service where there's the demand and you've got capacity to meet it, and the only thing keeping you from doing it is that you really don't want to pay a provider for an hour's drive out to a clinic, or you really need to bounce between 3 or 4 different locations or even 2 different locations rapidly, then those are problems that telehealth can help you meet. And once you know what kind of service you need to provide, then you can start looking at what are the technical needs and what are the kinds of platforms that we can deploy to meet those needs. And this probably is obvious and probably goes without saying, but unfortunately we come across so many programs that will call us and say either, yeah, we tried telehealth, 10 years ago, they bought some equipment, it's sitting in a closet here somewhere, nobody knows how to use it. It was just, so they spent the money first and never figured out what to do with it. Or they'll say, hey, we want to do a telemedicine program, we just bought some equipment, can you come out and help us and show us how to do it? And at that point, the chances are kind of 50-50 that what you bought is going to ultimately be what you need, or at least the most effective way to meet your need. At least that's our experience. And again, we're not trying to say that we know better than you what you need, but there are a range of things out there, and I just encourage you to take it slow on the equipment and technical decision-making process, figure out the service-based and the administrative issues first before so you know what sorts of things you actually need to support with your equipment choices. An integrated medical record or medical record shared between behavioral health clinician and the primary care provider is absolutely key. If you can do that, great. I mean, if you can't, you can't, but if there's any way you can do that, I highly recommend it. You probably need to cover some policies and procedures that should primarily mirror what you would normally do. So keeping your policies regarding telehealth at a minimum, and then mirroring or aligning those procedures with your on-site, in-person process is the best practice. You don't want to create a whole different system for telehealth than you do for regular in-person care. And we can talk more, give you more ideas about that. The only caveat is that at the bottom of the page here, you have to have some alternative procedures in place, because there are certain times when your provider cannot lay physical hands on the patient. So for example, if an encounter can't be completed as planned for some kind of technical reason, or a power outage, or the camera's not sufficient for making the diagnosis, or the equipment is not working, or whatever, you have to have a way of transferring care back to the local clinic, which usually involves getting somebody on the phone or somehow getting someone's attention to come into the room and intervene. You have to have a way to do that. In fact, you have to have a way to do that emergently. In other words, if a patient gets into some sort of a crisis. I had a clinician once who was working with a patient. The patient was referred rapidly without a whole lot of thought on the part of the originating site clinic. She was anxious. She came and sat in front of the camera, was working with the clinician, and had a panic attack. And there was no one else in the room. And the clinician had to be able to call a number and get somebody into the room to help this patient de-escalate and take some next steps. And so you need to be able to do that. Also, I list here just the generic steps of returning control to the local site, and then re-engaging the local site in existing on-site procedures. And what I mean by that, for example, is people will often say, well, what happens if a patient is seeing a clinician by telehealth, and suddenly a psychiatric emergency arises? They threaten suicide or whatever. Well, what would you do now without telehealth? That happens in primary care from time to time. What are your on-site procedures for doing that? You call law enforcement, you call an ambulance, you do whatever you do, right? So your procedures with telehealth want to connect with that on-site procedure as seamlessly as possible. So the main thing is getting somebody into the room to assist if they're not already there. Also screening, of course, that you don't want to put high-risk patients in that sort of a setting, in a telehealth setting, but reintegrating the patient into existing on-site procedures for managing emergencies is really what you want to emphasize. And again, we can help you with details there. So I have a limited amount of time left, so I'm just going to give you I'm going to throw some technical things out there just so you have an idea of what we're talking about technically. I'm imagining that most of you have these ideas already, but I'll show you a couple of things just to keep to think about. When we first started doing telehealth at the Upper Midwest Telehealth Resource Center, what was previous project, we learned very quickly that telemedicine equipment starts expensive, but it continues to get cheaper and cheaper. We started with a very inexpensive appliance endpoint that cost about $5,000 per unit, and you see a picture of one there. But within a year, we had found a way to do that with a generic computer and software that saved us a lot of money, and we could deploy those units for about $1,000 rather than $5,000. Currently, there are units like this. This is the type of unit that Oaklawn, the Community Mental Health Center here, is deploying. They're about $1,200 or so. And it's just a generic all-in-one computer running some software. It has an it has a webcam and an audio subsystem that can provide a little better microphone and speaker than what's built in, as well as a webcam that does better than any built-in webcam, really. And then a cart to run it around, and a mobile power supply. So you can run this thing wirelessly if you need to. Most likely you're going to be plugging it into the wall. But you can see that the cost is going down. You can even do telemedicine from a desktop system or any laptop in a pinch. There are definitely best practices you should be aware of if you're going to try and use inexpensive equipment. I'll give you an example. You're running an iPad to do a video conference, and you're holding the iPad, okay? The person on the other end is either going to get seasick or irritated that you cannot hold that iPad still. Put it on a rack. You also don't want to be looking down into your lap for a video conference, whether that's with a laptop sitting at a low angle or tablet or whatever. Get the camera up so that it's shooting straight at you. This is how we have conversations. We don't have conversations with people in our lap, so at least most of the time. So these are just some best practices to be aware of that aren't obvious first time around when you're setting up equipment. You're also, if you're going to have clinicians working on this for extended periods of time, there are ways to make it more comfortable as well. Have a little distance between them and the screen. Just some things that are best practices. So consult with people if you're with knowledgeable folks if you're interested in doing these kinds of things. In behavioral health, we don't usually have to worry about peripherals, so I'm not going to spend much time on peripherals, but just know that they are available. Stethoscopes, various kinds of cameras, otoscopes. If you're going to use those, of course, you're going to have a local operator or presenter, and that person will need some training and some skills. So don't just assume that you can throw this equipment into somebody's hands and they can be fine with it. So spend some time thinking about that. I include a few resources on integrated care and the telehealth resource centers, which are a fabulous repository of information. 14 centers across the country. Be sure and make use of that as well. And that's a little longer than I expected to take, but we have a little bit of time left for questions. So let's go ahead and transition into the question and answer period, and I'll let you sort of direct on that.
Yes, now we're open for any question and answers. You can use in your lower part of the screen the Q&A part to ask your questions. You can click on that and ask the question, write it in there, or you can use the chat box. I think you were pretty thorough. They don't have any questions yet.
One can always hope that that's the case. And I will say too, I mean, all of you who are accessing this webinar, you know that you have access to the Upper Midwest Telehealth Resource Center or any of the telehealth resource centers. And you should know, if you don't already, that we really do work on a consultative basis. We're here to answer questions. The best way to use us is to get in touch with us. Don't just read material on the website or watch webinars, but if you have questions, do follow up, do ask specific questions, and we'll provide more specific answers, because it's just so difficult, and we've learned over the years it's difficult to provide one answer for everybody, because it is wrong in more cases than it's correct. So so encourage you all to follow up specifically with questions.
Yes, and just so you know, the recording for this webinar would be available at the UMTRC YouTube channel, and Dr. Neufeld will send me the slides that I would be sending out to all the attendees. Oh, looks like we don't have any questions.
Okay.
All right. Thank you so much, everybody, for joining us, and thank you so much, Dr. Neufeld, for your presentation. And please check out our newsletter that would be sent out early in June for the upcoming webinars and events. Thank you.